I've already elevated what we call the tympanomeatal flap, which means the tympanic membrane and the skin of the posterior half of the external auditory canal. What you can see here is the prosthesis, which is in fact dislocated from the incus, but the incus is intact, which is a really good news. You remember when we talked together, I was thinking that maybe there could be an erosion of the incus, but your incus is very strong, still thick, so there's no problem, we can preserve it. I remove this fibrous tissue, and now I'm going to remove this prosthesis. So it's only a dislocation of the loop, trois de chouk, which is very rare, but it could happen. And now we'll remove the prosthesis. All right, and now I will dissect this fibrous tissue and try to approach the scissors, s'il vous plaît. Vous me mettrez de côté, s'il vous plaît? Oui. D'accord? Dans une petite boîte. Oui. So I remove this fibrous tissue here again, trois de chouk, and I will expose the Stapes foot plate in order to perform a new fenestra, as we discussed together. So left ear means that this is 12 o'clock and 6 o'clock is here. All right, and what I'm going to do here is checking malleus incus mobility. Canley, although I think there's no problem with that, looks really good. I'm going to move the malleus here, and you see the incus is moving very well, so there's no problem with that. Okay, now in the deep we can see the Stapes foot plate, and what I intend to do now is to measure the distance from incus to foot plate in order to determine the prosthesis length accordingly. Measure. Okay. And now I'm going to measure the distance now from the Stapes foot plate. I can see the previous fenestra, which was performed by my very good friend Bill Moretz. And you can see it's quite a long one. We here more than 4.5, so it's going to be a 4.75 long prosthesis. Okay, so I will use the previous fenestra, re-fenestrate the labyrinth slightly, and then put a vein graft again. That's it. Okay. What I intend, we try to seal the labyrinth with the vein graft, as we discussed together. Alright, I'm going to use now a 0.7 millimeter diameter suction tube, and with my right hand I use the micro drill, which is a 0.7 millimeter diameter diamond dusper, a low speed drill. Okay, refenestrating this perilymphatic membrane you can see here, and we will have a nice fenestra. As you can see, it's fine, so I'm going to cover it now with the vein graft, which I took at the beginning of the procedure. I'm going to pre-shape the vein now and put the vein over the foot plate. So it's a pretty large one, so I'm going to cut and use only a small part of this with the intima of the vein, which is facing the surgeon. You can see I'm cutting it, and use only this part of the vein. That will be enough, I guess. That's very important for especially when we use a torp, but even with a piston, we believe it helps a lot to protect the inner ear and to seal the labyrinth, avoiding any fluid leakage, which means perilymphatic fistula, which could happen, of course, following any type of operation, but with the vein graft, we definitely decrease the risk and the incidence of the fluid leakage post-op. Alright, so now I'm going to place the vein graft. I'm going to interpose the vein here, stretching it over the Stapes foot plate, holding it with the sucker, and then introducing it, with the sucker, and then stretching it with the needles. Pretty large vein graft, but I think it's very nice. It helps a lot to have a knife like this. Okay, I want to stretch it better in order to cover completely the anterior part of the vein. donnez-moi le crochet aussi. I have some fibrous tissue which is remaining here, and I want to remove it because it doesn't help me to stretch correctly the vein. Now I can do it. Cannelé. Comment? Oui, oui, bien sûr. There we go, and now I press the vein here over it. There is a small erosion of the incus, but it's nothing, so it's going to be fine. So I just take my time to stretch the vein perfectly, and now I think it's pretty good, and that will be okay. Crochet aussi, s'il vous plaît. Okay, cannelé. Okay, now it's much better. We have a nice position of the vein. Okay, it's fine. And now I'm going to prepare the prosthesis, which is 0.4 millimeter diameter teflon prosthesis, which I'm going to cut at 4.75, a little bit. That's the length I measured. So I'm using now a cutting block. Okay. Okay. Oh. I need another one. Okay. All right. So give me donnez-moi encore la pince. All right. I'm going to bring it with the crocodile forceps. I'm going to put it at 4.75, which is the corresponding length. As you know, you can see it's a little bit of a smaller, I think, diameter prosthesis than the one which was used by Bill. This is 0.4 millimeter diameter teflon shaft, which I think was 0.6 probably, but the previous one. Okay, I'm now opening the loop of the piston, and then I will introduce the piston. First, I will introduce the piston within the labyrinth, within the fenestra, and then I will put the loop around the incus, and then finally I will close the loop around the incus. There's always a little bit of a blood around, but not that much. Okay, so now I'm going to place the shaft within the fenestra like this, and then placing the loop around the incus like this. And finally, I just need to crimp the loop. Okay, I need to place the loop around first, like this. There we go. And now I just need to crimp the the loop. We're using two hooks. So one is used to hold the loop, you say the left one, and the other one, the right one. The right one is used to close the loop around the incus. And of course we need to close it as much as we can close to the incus in order to avoid any recurrent prosthesis dislocation. That's the way. So I think it's going to be very stable now. There we go. Alright, so let me see how it goes. I think we have a nice position of the prosthesis, and I'm going to look for what we call the bending sign, which means that to be sure that the prosthesis is located within the fenestra because it's hidden by the vein graft, I'm going to try to move the piston shaft, and the piston should the shaft should bend but not move. You can see it's bending clearly, so it's fine. I think it's in a good position. The vein is there, protecting the inner ear nicely, and you see the bending sign is clear. Alright, and now the mobility from malleus is pretty good. Okay, it's finished, so I'm going to reposition the tympanomeatal flap, and then placing a Merocell within the ear canal, And this mirror cell will be removed next week, as we discussed. Allez-y. Oh, this is the mirror cell, and I'll remove this mirror cell next week. Okay, I think all went well, and the cause of failure was a pretty easy one to treat with, because there's nothing more than replacing by a new prosthesis the previous one, and usually it's giving really good results. So thanks again for your confidence, and we'll talk about that together later on. Bye-bye.